Put your feet up. I think Anna's the
Yeah.
same. So, all right. Well, I might, I'll make a slow start, and I'm sure a few others will join us. And Michele has agreed to record this, so we will pop this up on our website as well. But yeah, happy Friday to those of you who are here. I would like to begin by making an acknowledgement to country and to pay my respects to Aboriginal people who might be with us today. I'm on the lands of the Wurundjeri people of the Kulin Nation, and extend a warm welcome to everyone to this Deliver webinar. It's the second in our series, and we're delighted to have Michele, Associate Professor Michele Callisaya, present to us today. The goal of these webinars is really to connect and discuss on topics relevant to the Deliver research program. And certainly today's presentation is meeting that goal. So Michele is a Senior Research Fellow and Associate Professor at the Peninsula Clinical School at Monash University, and also Principal Research Fellow at the Menzies Institute for Medical Research, University of Tasmania. And Michele is a Chief Investigator on the Deliver grant. Michele has a background in physiotherapy, having worked in the field of rehabilitation for over 20 years. She completed her PhD at the University of Tasmania, and then went on to be awarded a very competitive early career research fellowship from the NHMRC, followed by another fellowship on boosting dementia research, which is fantastic. Michele is passionate about promoting the role of physiotherapy for people living with cognitive impairment, dementia and stroke, and her work has led to better understanding of the role of cognition on physical functioning and adverse events such as falls. Her current projects focus on improving access to rehabilitation for people with dementia. So the title of Michele's presentation today is Learning and Outcomes from Co-Design, the Right to Rehabilitation for People with Dementia. Thanks very much, Michele.
Thanks, Kate. That was a very long introduction.
No, not at all.
No, thanks so much for inviting me. I'm very passionate about this topic of the right to rehabilitation for people with dementia. And what I thought I'd do is just present some of the background to the project first, because it's really great advocacy as well for the topic. And then, the focus is really on reflections and learnings from the co-design phase. So I'll present the methods and results, but intertwine those reflections and learnings throughout. So I'll just share my screen and hopefully this works. Now, can you see that in the full screen mode?
Not yet. So at the moment, it's still in, we've got the slides down the side as well.
How about now?
Perfect.
Excellent. All right. So I'm just going to start off with two case studies, and I want you to think in Australia today, what would be offered to this person? So Pat's 74. Before retiring 4 years ago, she worked as a teacher. She now volunteers and is married with 2 grown-up children. She loves to catch up with friends. She belongs to a croquet group. But over the last year to 18 months, she's really withdrawn from a lot of these activities. She was recently diagnosed by a geriatrician with Alzheimer's dementia. She's experiencing a number of difficulties, word finding and following conversations, forgetting people's names. She's had 2 falls in the last year, and she's having some difficulties with food preparation, particularly she's left the pot on the stove. So maybe just very quickly pop in the chat what you think would be offered to her generally in Australia today. Or call it out, I don't mind. Can't see anything. Nothing would be offered? Support group, not really sure. Memory group maybe, yeah. Referral to Dementia Australia, an assessment, a jury assessment, yeah. Great. All right. So I'm going to go move on to the next one. So Brian is 74. Before retiring 4 years ago, he worked as a lab manager. Now he volunteers as well, making props, and he has a partner, 1 grown-up son. He loves going to the pub and occasionally cycles for exercise, and he's just been discharged home after experiencing a major stroke, and he's been in hospital for 6 weeks. He's also experiencing word-finding problems and understanding instructions. He's got weakness in his left arm and leg. He can't ride his bike. He needs assistance for walking with a stick and also a minimal assistance for dressing and showering. What do you think he might be offered? So just, yell it out or very quickly pop something in the chat. Yep, community rehab, yep, support group, rehab, yep, excellent. So lots of people saying rehab. So let's hopefully this will move on. So basically the current dementia post-diagnostic care for people with dementia involves medications, looking at their safety to drive, and advanced care planning and power of attorney. And mostly supports are aimed at doing things for the person rather than really supporting them to continue to do things. And this has actually been coined deprescribing life by a dementia advocate, Kate Swaffer. It can lead to further loss in function, depression, and poorer quality of life. So there's a real push by advocates, and there's growing evidence for rehabilitation for people with dementia after a diagnosis. And we don't usually use the term rehabilitation with dementia. It's often something that we use and think of in terms of stroke or hip fracture. But the World Health Organization is adopting this term, particularly for people with dementia. And so we've used it in our project for post-diagnostic dementia care. So what might rehabilitation look like for someone like Pat? Well, it should try and at least maintain or slow loss in function, or even improve it, maintain her independence and safety for as long as possible, and particularly focus on maintaining meaningful activities and relationships. And for her, she loves cooking for her family. She loves croquet and being with friends and family. So it might be that an occupational therapist comes around and looks at some simple recipes, breaks them down into simple tasks, declutters her very cluttered kitchen, and puts all the ingredients that she needs in one spot and labels cupboards so things are easy to find. Later on, she might need assistance from either a support worker or family, but it's still about trying to make sure that she's involved in the activity rather than taking it over for her. A speech pathologist might come and do some language interventions. So, for example, to remember people's names, there are association tasks. So for myself, Michele, someone might picture a shell on the beach, or for Rosie with red hair, it might be red-haired Rosie. As time goes on, the person might need aids and technology. So she may need a cue card like this, for example, to go to the coffee shop. And friends and family might need support with problem solving and communication strategies. A physiotherapist might come along and give her some balance and functional exercises to prevent falls, but also to help her maintain the activities she enjoys, such as croquet. There's growing evidence, as I mentioned, for dementia rehabilitation, and I was involved in both this dementia rehabilitation book that was published in 2020 and also this package of interventions for rehabilitation specifically for people with dementia from the World Health Organization. The book covers all sorts of interventions, all the way from communication interventions to leisure interventions and activities of daily living and driving. In Australia, we've got policy and position statements. Really looking at access to allied health is something that's really important in terms of maintaining independence, quality of life, and keeping people at home for as long as possible. But rehabilitation, unfortunately, is really underprescribed in Australia and around the world for people with dementia. So that's what led to this application that was, must have been, probably 2 years ago that it was actually written. And really the first reflection that I'd like to share with you is just how important it was to have the right partners in the room for this grant. We had a number of universities, but really importantly, we have a couple of different allied health professional national organisations, 2 organisations that support people with dementia, and 2 primary health networks where we wanted to roll out the interventions. And so these organisations have been so important both in the co-design phase, but particularly in terms of making sure that we can roll out these interventions and that they're going to have reach and sustainability as we go forward. So just to be, I suppose, really clear, this is not about providing more evidence for rehabilitation. This is really trying to tackle the stigma around it and really trying to make sure that it's implemented. Before we started the co-design process, we already had a number of publications from our group. And it really showed that there was stigma around dementia rehabilitation, and that many health professionals thought that people with dementia could not engage or improve. And this is certainly not true, and has been shown by the evidence that it is possible. There was a real lack of knowledge around dementia in general. People with dementia and care partners didn't know a lot about dementia rehabilitation and where to find or ask for it. And finally, this last article, really we showed that there's not really a model of care or pathway for dementia in rehabilitation in Australia. So it's not surprising that people with dementia themselves don't know where to find it. So really the aim of the co-design process was to improve access to rehabilitation by empowering people living with dementia and their care partners to be able to ask for it, to address stigma and low knowledge of health professionals, and promote collaborations and pathways to rehabilitation. And as you'll see, it was a fairly simplistic view in hindsight, and the co-design process was really important in understanding that a lot better. There are many definitions of co-design, but I really like this one, particularly the listening, learning, and making decisions together. So how did we go about it? Well, we had two groups, a professional group and then another group, which we will call the lived experience group. They were the people with dementia and their care partners. You can see in the professional group, we had a wide range of different professions, but also people from different organisations. For the lived experience group, we really wanted to focus on having diversity, particularly with age and gender across the states and territories of Australia, rural and urban areas, and cultural backgrounds. And Dementia Australia was really fantastic in helping us achieve this. They had someone dedicated to helping us write the advertisement. They sent out the advertisement for us and recruited people so that we really met those diversity and equity filters. Dementia Alliance International is an organisation run by people with dementia for people with dementia, and we also were able to have people from there come into our workshops as well. We had 3 workshop facilitators, so Dr. Natasha Layton on the left, who's an occupational therapist, Catherine Devaney, who's also an occupational therapist, and myself. Dementia Australia also provided us with a number of really useful resources, and we found some ourselves. So if you were ever going to work with people with dementia, really strongly recommend these. The first 2 look at language and images, and if you look through your health service and on social media, you'll see some really, I guess, negative pictures and images about dementia, and these documents are really helpful in making sure you get it right. The 3 in the middle talk about meaningful engagement with people with dementia, and we use these really to look at the things that we would need to do in terms of being inclusive for people with dementia. And then finally, on the right-hand side, we used 2 different documents for the actual co-design process. So one was an experience-based co-design toolkit, and we broadly designed our methodology on this. And then the Department of Health has this stakeholder engagement framework, which we use some principles of engagement from, which I'll talk about in a couple of slides. So in terms of the methods, we had to decide whether to have face-to-face or Zoom. And in the end, we did decide to go through with Zoom because one, people were still concerned about COVID at the time. We had people from all across Australia, and we also had people with poor mobility or potentially who were a carer and really couldn't come to a workshop without a lot of effort to get somebody to stay at home. I guess the disadvantages of that were that with face-to-face, you would have probably had more interaction. There would have been a lot more reading of some non-verbal, I guess, cues, and the workshops potentially could have been a little bit longer. So we ran 3 workshops. The first 2 were 2 weeks apart. I think it was 2 to 3 weeks apart. And then workshop 2 and 3 were 4 weeks apart. The first 2, we had the 2 groups separately. And then in workshop 3, we brought everybody together. In workshop 1, we really tried to understand more about the barriers to access to rehabilitation. And we looked at those 4 different areas, but it wasn't limited to those. In workshop 2, we used this understanding of the barriers to look at potential solutions for the different groups, people with dementia, GPs and specialists, allied health professionals, and also potential pathways. We then went away and had all these solutions and talked to our different partners about what might be feasible in the time frame. We wanted to avoid duplication, but we also wanted to potentially have national reach and sustainability in the solutions that we could do. We took these back to workshop 3 for checking and refinement. So probably the biggest, I guess, learning and reflection for me, having not done a lot of co-design, was how important these principles of engagement were from that Department of Health stakeholder engagement framework. And I really want to thank Natasha for doing a lot of work on these. So they're down the side there: purposeful, inclusive, timely, transparent, and respectful. And what we did is Natasha translated these basically for what they meant for our project. And then we presented these at every single workshop, and we made sure that the co-designers held us accountable for sticking to these principles of engagement. And also as a team, we really tried to enact them in every interaction that we had. So I'm going to talk about a couple of them, particularly the inclusive, transparent and respectful, the ways that we went about trying to do this, particularly with people living with dementia and their care partners. So one of the things that Dementia Australia suggested to us is that we have this pre-meet and greet workshop with the lived experience experts. And this, I must say, was absolutely essential. We put it in only a week before the first workshop, which was just, on reflection, we should have had it a lot earlier. So what we did is we asked people to send in their photos and a very short bio about themselves. And then when we ran the workshop, which was an hour, we were able to introduce everyone in a timely fashion. We took them through Zoom. They didn't have to have experience with Zoom. We took them through things like, being able to put their hand up, having their name on their screen so that everyone knew who they were. And we also talked about the timing of the workshops. So, for example, most people said that for them, mid-morning, midday was around the best time for them. We talked about breaks, what they would need, whether they'd want reminders and whether that would need to be email, phone call, text, and whether they needed any assistance. And so Catherine's reflection on this was it really helped to develop a culture, safety in speaking up as well, and giving them the power. And we made it really clear that we were inviting feedback and critique on how we ran the co-design workshop and making sure that everybody was heard. My reflections were that it really helped us to get to know the co-designers, who was going to speak a lot, who wasn't going to speak up, and what needs they would require during the workshop. It was also really important to understand that our staff knew how to facilitate workshops with people with dementia in terms of not speaking too quickly, giving people time to respond and repeating things if needed. So we did make some changes after the meet and greet workshop, and I'm just going to play this video of Catherine talking about how we changed language and also how she needed to provide assistance to one of the participants or workshop co-designers.
We used the word consumer in some of our literature, and we were told that's not the word, that's not a word that sits right for us, but preferring to be talked about living experience, or also talked about just if you're talking about people with dementia, call us people with dementia and don't call us consumers. One participant actually had trouble joining, so joined the meeting and looked like they were going to be able to take part, but then there were some issues with audio and video and dropped out. And so being able to show that respect for having, the person having made all this effort, sort of being able to send her a message while we were still in the meet and greet, sending her a message saying, I noticed that you were having some technical problems. I'll give you a call after and make a plan. And so then being able to catch up with her separately, have a separate practice session where we could sort of troubleshoot and also make sure that she actually felt valued and welcomed and ready to join the next meeting.
Yeah, so a couple of the other things that we did, we realised that not everyone could do consent via email, so we had to change our ethics very quickly, and we were allowed to do telephone consent. Some people were using their mobile phones, so they couldn't see PowerPoint, so we quickly had to send by express post some hard copies to people. We had personal reminders, and we also offered people one-to-one opportunities after each workshop in case they felt that they hadn't been able to get their message across or they wanted to tell us anything else. And we had that one person, Catherine, as the point of contact, and really important that this person has excellent communication skills and really makes an effort to make sure that the people with dementia feel like they're being heard and they feel comfortable. And Catherine was really fantastic with that. Also, in terms of being inclusive and respectful, we provided briefings before each workshop and also summaries of each workshop so that people could check it and get back to us if they thought we missed anything. As we were running the workshops, we had PowerPoints that we wrote on while we were doing it so people could make sure that we were recording what they were saying, but we also recorded the workshops as well. We kept checking in and making sure that we'd captured people's contributions and making sure that everybody was okay. And really importantly, as I mentioned, we tried to embed respect and value into every interaction. This did take time, and I'm just going to play another video on Catherine's reflections.
Had been there were some participants who perhaps were worried that the information they shared, whether it had sort of come through in the way that they meant, and wanted to talk back afterwards to double check that. And so some of the types of things I would do would be to have a follow-up phone call or a follow-up one-on-one Zoom session with a couple of the participants who asked for this kind of check-in, to be able to check and to be able to confirm that yes, what they talked about was featured in the summary. We did capture that information and be able to really, I guess, honour their commitment to making sure that those points got shared. But all of these processes do take that extra time responding, and it was actually quite a joy because it was quite an easy thing for me as time went on to be able to say, I really mean when I'd say really cool being able to put those words.
So I hope you can see how valuable Catherine was for this process, really passionate. Oops. And then we had also personas and pictures. So we knew that we had a lot of text and we wanted to make sure that I guess it wasn't too text heavy. And so we got a cartoonist to make these pictures of Lee, who was diagnosed with dementia, but unfortunately he didn't get to hear about rehabilitation. And here you can see that the gardening was taken away from him, and so he became quite depressed and withdrawn. And it wasn't until 2 years later, really, that he got what he needed from an occupational therapist. The other thing I think that was really important was being really clear on the scope of the project. We found really early on in that pre-meeting that people wanted to talk about not getting a dementia diagnosis early enough, or what about people in residential care. So we were really able to set up the scope around the project from the workshop number 1. And that involved saying that it was going to be in the community. It was a limited trial on a limited budget, and that we couldn't change things like government funding. So what about the results? So as I mentioned, we had a fairly simplistic view, and this next slide is deliberately busy. So these were all the things that people brought up as barriers potentially to the program. So this is the access to healthcare Levesque framework, and on the top you can see all the personal level barriers, and so ability to engage, pay, reach, seek and perceive. And then down the bottom are the system level barriers at the health professional, organisational, community and government level. And they came under the domains of appropriateness, affordability, availability, acceptability and approachability. And I'm not going to go through them all, but I'm just going to give you a taster. So stigma was a really important one. And so there was health professional stigma. They think that because there is no cure, there is no treatment, and that's not true. Or the reluctance to diagnose delays therapy and reduces quality of life. Or potentially self-stigma. My husband didn't want to see the doctor. He was fearful of being labelled. Or community or organisational stigma. Discrimination and stigma lowers expectations and disables you. Or we are deprioritised and excluded from therapies. It's a human rights issue. Knowledge was seen as the basis of all problems and the key problem leading to stigma, disempowerment and lack of availability of services. And people said, look, there's got to be someone out there delivering the goods to have a successful pathway. We need people at the other end who are accepting referrals. And so really it was tricky because there weren't a lot of pathways. Funding models and services were commonly non-existent, or if they did exist, they were fragmented or hard to navigate. And funding barriers included issues of financial viability, serving people under My Aged Care when the reimbursement for My Aged Care services was lower than NDIS. So you can see how complex it was. So what did we come up with? It was actually really tricky to come up with something that was going to be feasible in the time and successful if we weren't able to address all of these. And so I'll just give you a very brief overview of what we've decided to do. We didn't want to duplicate anything, and so it was decided that we'd do a dementia rehabilitation e-course, and that was a real gap, and that's going to be trialled in the 2 primary health networks with allied health professionals, but also aged care assessors and NDIS assessors. And hopefully later on we'll be able to roll it out into the community as well. We're also going to have a community of practice to try and improve mentorship, but also break down some of the fragmentation. We're working with Dementia Training Australia. They go around Australia with the primary health networks, training up GPs and nurse practitioners on dementia, and we're going to put more on allied health and dementia rehabilitation into that training and evaluate it. We'll update the Dementia Australia guide that is given to people with dementia and their care partners with more information as well on dementia rehabilitation. A really nice outcome was that one of the primary health networks went away from our workshops and actually used some government funding to set up a dementia rehabilitation program in the area, and that started and is going really well. And GPs are saying how fantastic it is to have somewhere to refer to. And the feedback from care partners is that it's great because they've got people to ask lots of questions, and it's a little bit like a navigator service. We'll also work with the local dementia pathways to make sure that people know where to refer to. Some of the things that we weren't able to do, but we're still reporting and recording on, is that people wanted dementia navigators. They wanted more through peer and carer support networks on dementia rehabilitation and better funding models. And this is really just a cartoon where we demonstrated what that might look like for Lee if everything went well. And so some final reflections, firstly from the co-designers. This is what they said in that last workshop. I think it's really good that the project is working on highlighting what can be done, because it's really tough when there's limited knowledge, including among professionals, about what can be done. And let's focus on what we can do, being really mindful of what we still can't do, and keep on fighting for all of those things. From my reflections, I think some of the positives and what we did well was that the co-design brought a really in-depth understanding of problems and solutions. What we did well is I think we were really clear on the context and the scope, so that when we couldn't do things at the end, people weren't disappointed. We really had the right partners and also people in terms of the co-designers. They were so knowledgeable, passionate, enthusiastic, and we had nearly 100% attendance across the 3 workshops. Having the right project staff, we had someone really experienced in co-design, as well as Catherine, who had just these fantastic communication skills with the co-designers. Really important to have the resources to do it well. We had 3 facilitators. We gave ourselves 6 months to do it. just thinking about things like, money for postage and gift cards and creating the visuals, I think we did really well. And we're closing the loop. So we're sending out newsletters to keep people updated with what we're doing, and we'll have a final workshop at the end to refine the solutions. In terms of what was hard and what we could have done better, well, certainly really, really hard about not knowing what the outcome's going to be and whether we're going to come up with solutions to implement. As the leader of the grant, it was certainly quite anxiety provoking. The group sizes, we did have breakout groups, but still, particularly in the last workshop where the group sizes were bigger, it was difficult juggling, letting people speak and getting everyone's thoughts and the time available. Certainly, we could have had more lead-up time and more time between workshops to create visuals and send out better information. Some of the information still was very text-heavy, and I think we could have done better with that. In terms of diversity of the co-designers, we did try really hard with those filters, but a lot of the co-designers were very experienced, and I guess I wonder whether we really captured the broader extent of people with dementia. And finally, we didn't actually offer any counselling, which I have now seen that is recommended for any co-design work. And I think in hindsight, it probably would have been important in case it brought up any issues for people. And certainly the co-design process really, for me, makes me far more a feeling of accountability to really make the effort to make sure that these solutions happen. And so just finally, I just want to acknowledge the larger investigator team there on the left, fantastic project team, which also includes, I haven't got, Natasha's one of the main investigators, but the project team here also Angel Lee and Kim Teresi, who's a speech pathologist, and all the different partners. And that's it. Thank you. Hopefully I kept to time.
That's fantastic, Michele. Yeah, no, that's great. And we've got about 5 minutes for questions for anyone that can stay on the line, but that's really excellent work, and I'm pleased you're able to share that with us today. I am going to open up the floor to a few questions, or if you've got any that you want to put in the chat, and certainly if there's any that we miss, we can respond to you later. Anna.
Thanks, Michele. That was fantastic. And yeah, I think you really clearly outlined both the need. I really liked your first slides, but also the process. I mean, I was really interested in that diversity question too, and I just wondered if you had any further reflections on, in the development, for example, the resources that might come next, how you might tackle that, and how we more generally might try and encourage more diversity in the people who are involved in co-design and co-development.
Yeah, look, I think it's really tricky. So certainly in the Dementia, Dementia Australia has a number of dementia advocates, and so you do see the same people kind of volunteering for projects again and again. And I think it's hard because, obviously some people don't want to, be involved in projects and things. But one of the things that we did try and do after getting all Dementia Australia was go to Dementia Alliance International, and we did get 2 more people from Dementia Alliance International. But I think it would require a lot more resources and time to really go out there and try and find other people, potentially through, our allied health and health service contacts as well, and get different people involved. Sorry, what was your second question?
No, that was just one question.
Oh, yeah.
And there's a great comment in the chat from Sandy. Amazing work, and thanks for sharing absolutely invaluable information for future co-design work. So that's great. I might ask a question if there are no others at the moment. Michele, during the co-design, so you obviously were co-designing for solutions, did you simultaneously think about asking them about outcome measures? So if you were to obviously implement some solutions, and then to be able to, effectively monitor whether they're achieving the intended goals, did you get any input into what you should be measuring as outcomes?
No, we didn't. And I guess the problem was we didn't know what the solutions were going to be until that very last workshop. And I didn't say each workshop was 90 minutes and had a very short break, apart from the last workshop, which we just didn't have time to have a break. It was just, on reflection, not enough time with the amount of people that we had. And I think with face-to-face, you may have got a little bit more of that. In terms of the outcome measures that we will use, we're going to look very much at change in attitudes and knowledge of the people that do the e-modules and the community of practice, and also look at a social networking analysis and so we'll basically look at how connected the different health professionals are at the moment, and then at the end of the project look and see whether there's any change in that through the community of practice. We'd initially thought that we would be able to use GP polar data to look at GP referrals. But since then, I think it's going to be really difficult. I mean, one of the, I guess, fantastic things out of the project was that one of the primary health networks went and did this, you know, put together this tender for a dementia rehabilitation project. But in fact, the referrals are phone referrals and won't be reflected through polar GP referrals. So we won't be able to do it. So I think it's really hard when you do this co-design process and this uncertainty of what you're going to come up with. It's really hard to plan. And we had 4 months, I think it was, between workshop 2 and 3. And, you know, we were just working so hard to kind of get together something that was feasible, and the partners were really important to think, okay, well, once this project's finished, how are we going to keep this going? You know, so Dementia Training Australia continuing on with the GP training is going to be super important. We need to get Dementia Learning Australia. They've kind of said that they hope they'll be able to take on the e-module. Yeah, so I think it's just really tricky. You know, you could probably have a whole lot more workshops if you wanted to cover the outcome measures as well.
Yeah, no, that's great. Thanks. Anyone else got a final question?
I had one. Thanks, Michelle. I love the presentation. I have had my headspace, I guess, in grants just most recently, and I was just wondering how, whether you, I might have missed it, but did you include consumers within the grant? And, you know, do you have any strategies for us to be able to do that?
Yeah, we did. So we had someone living with dementia as a CIC on the grant. And so I think that was a really important thing to do. And so, yeah, they had input saying that they also have a number of other amazing skills as well. I won't go into them to give away their identity, I suppose. But yeah, I think that is really important. And I think from what I've seen is it's becoming more and more common to do so, and getting that input, but really supporting that person if they don't have experience, the person that we had past experience in being on grants before. Because, you know, you've got to then get them to help them through Sapphire if it's a Sapphire grant, and all those kind of things.
To help us navigate that process.
But I think also, you know, we have a salary for that person as well, which I think is really important, as you know, recognising their time and skills. Yeah, super important to remunerate them with that. Yeah,
thank you.
Fantastic.
I must say it's been a complete learning experience for me, and it's been really wonderful to reflect on it. And yeah, I think it's just such an important process that I hadn't, I guess, understood the value of it until we actually went through it.
Great, Michelle. Well, I'm sure many of the Deliver team will be drawing on your experience as we push through with the Deliver activities. So thanks again. And if anyone does have some further thought later and questions, feel free to either email Michelle or me, and we can respond to you. So thanks again, Michelle. Have a great holiday.
Thank you.
Everyone else, enjoy your weekend.
Thanks, Michelle.
Pleasure.
Thanks. Thank you.